that I'm Dr. Melendez. Oh, Sarah Melendez, you can just call me Sarah. And so I was told to come back and kind of speak about something that I'm passionate about. So obviously I love peds. So today is going to be a peds talk. It's more like core content because I think, you know, all of us coming from residency always feel like we don't see enough kids. So I specifically wanted to talk about sick babies. So just again, like they said, my background, I went to SUNY Downstate and I graduated with Allison and Jimmy and did my residency over here. Lived in Queens while I did my residency. That's what I drove every day leaving Brooklyn, the Belt Parkway, which is, And then I actually practiced in Orlando, which is Central Florida, at Arnold Palmer Hospital for Children. And that is the only level 1 trauma center for children in the Central Florida region. So we get a lot of kids flown in from pretty wide area in Florida. You may know the Orlando Health System because we're actually the ones, ORMC is the adult hospital that actually took care of the Pulse shooting victims. We're actually about 2 blocks from Pulse. So kind of a, you know, not so great day, but also we're 20 minutes from Disney. So that's the plot positive, and I love Disney. So I'm going to talk to you about the crashing neonate. And these are the kids that we all do not want to see, that we dread. And this is just to kind of hopefully get you feeling a little bit more comfortable with the sick baby. So we're going to go over the normal neonate because in order to see what a sick newborn looks like, you have to know what a normal newborn looks like. We're going to discuss some causes of the crashing neonate, just things that you should think of and cross off on your chart. And then just I'm going to talk about a couple of those in just a little bit more specific patterns and just kind of what you could do, some measures that you could do in the hospital, kind of temporize them to get them stable, to send them out, or to treat them and send them up to your NICU. So why is this important? And the biggest thing I think is that we're uncomfortable with babies. We're especially uncomfortable with little babies. Even as a PEM-trained person, I still feel uncomfortable when there's a sick newborn that comes into the ER. I think the only people that truly feel comfortable are neonatologists, but our goal is to make it up there, so that way at least your heart rate can stay somewhat normal. They have really rare diseases, things that you just don't see very often. And if you don't see many newborns, you don't see many of these diseases, except for what you read in your book and when you study for your boards. They're a difficult exam. They're newborns. They don't smile, they don't play, they just kind of lay there, sleep, eat, pee, poop, and then, okay, you know, and do it all over again. So what is that sleeping that newborn is doing? Is that bad sleep or is that just normal newborn sleep? They're difficult to get access on. Thankfully, pediatric trained nurses are great at getting IVs. And I'm very lucky to have them work with me, and you know, you guys work with the peds nurses here too. So they're very good at getting access, but if you can't get that, you know, there's other ways to get access, but it's not something that we feel very comfortable with. Dosing of meds. You know, how many milligrams per kilogram do I have to give? And then actually some meds actually have minimum doses that you have to give. Like you have to reach a certain number first. And then the neonatal resuscitation program is actually a little different than regular PALS. So how you do CPR and, you know, breathing ratio and just knowing that oxygen and that air is really the thing that's going to save them. So I'm going to start with the case, and we'll kind of go into the end of the case later. But basically, you have an 11-day-old that was brought in by mom for poor feeding and lethargy, and that's the word that we all hate. Mother states that the baby was in their usual state of health until about sometime that morning. Normally, the baby takes about 2 ounces of formula and every 2 hours, but this morning the baby only took about ½ an ounce and didn't really want to wake up. She noticed that the baby seems to be not sucking as well, and also seems to be breathing funny and having some trouble. On review of systems, we always ask for fever. That's the first thing that pops in our mind. No fevers, and everything else apparently is negative per mom. Birth history, very important in this age group, was a normal vaginal delivery, full term, no complications. Baby went home with mom within 48 hours. All labs were normal, according to mom, but you don't have access to maternal labs. Physical exam, you do pressure on the right upper extremity, you get 80/50. heart rate's about 190, respiratory rate's a little over 60, 65. Temp is, they're afebrile rectally. And then you get an O2 stat of 75% on room air on the left lower extremity. So you have the pulse ox on the left toe and you have the blood pressure cuff on the right arm. So what do you do now? And we'll kind of go into that in a little bit. So the approach, and this is an approach that you're going to say in your mantra for your boards and stuff. IV O2 monitor. Now with babies this young, sometimes the O2 is kind of something that you will start with, but you may taper off if you notice there isn't any improvement. And we'll go into why in a few minutes. With any patient in the ER, you should always go get your ABCs. I like to do kind of A, B, C, D, E, F, G. H is not appropriate in this one, but airway breathing circulation. Remember femoral pulses in babies. So open that diaper. You really have to look at the genitalia and really have to get those femoral pulses. D, so disability. You're looking for any kind of deformities. Unfortunately, NAT is a big thing. E, exposure. Look at them. Were they exposed to anything? F, if it's appropriate, a fast. Again, neonates, it's a little harder, but a fast is something to think of. G is a glucose, so glucose should always be on your mind. Always do an acute check or a point of care. And then H, not in this baby, but HCG. So I just do H because that's what I always think of in my head. But, God. And then Broslow tape, I don't know if you guys are still using Broslow tapes. Okay, so we use them. That's something to do. But just know if you're doing a newborn, the average newborn is going to weigh about 3.5 kilos if they're a full-term baby. So that's something to keep in your mind. Plus, it doesn't go below 3. So if you're below 3, you have a young, small baby. They lose their heat very quickly. So keep that baby warm. You may have to do everything in a baby warmer. Just make sure you have that ready. Birth and feeding history is really important, like I said, especially if their breasts are formula fed. Formula feeding is important. It is important to know how they're actually mixing the formula because sometimes people don't make the formula correctly. They over-dilute it, and there's electrolyte issues. And then you may need extra blood and labs. So if you have a very sick baby, you're going to get your usual things that you think of. You're going to get your CBC, you're going to get your CMP, your lactate, but other things you may think of, ammonia. We'll go into why that's important. You may want some extra labs and extra chemistry because you're going to send off maybe some organic acids. Urine. You want to get all this before you start doing interventions because once you start giving things, you may alter the results of those blood tests. And then just remember that for newborns, the number 40 should be in your mind as a low blood glucose. So less than 30 in the first 24 hours, but less than 40 after 24 hours of life. So normal neonate, normal resting heart rate is in 120s to 160s. 160s being the higher number, but it's okay as long as they look well. Respiratory rate, 40 to 60. Again, as you approach the higher numbers, it becomes more concerning. Remember, they have periodic breathing, which is that irregular breathing due to irregular respiratory center in the brain. Systolic BPs, I would say 60 is the lowest. 60 is really the lowest you should go. 90 being kind of, 70 is where you're more median ranges, and that's okay, but less than 60, you start to think hypotension. And remember, hypotension is really bad in kids. So the first thing to go, that's the last thing to go. So they'll put their heart rate up, and then if they get hypotensive, their heart rate's just gonna drop, and they're gonna code. And then cap rate refill should be less than 3 seconds, but you can have acrocyanosis, so just remember to kind of just look for that. And then tone babies have this tone kind of look. They hold their arms up and they kind of hold their legs up. If they're just kind of laying on the bed, that's abnormal for a newborn. And just to know, just kind of basic things, bottle-fed babies get about 150 cc's per kilo per day. That can kind of give you how many ounces. Breastfed babies, it's very variable, but as long as they're making adequate urine output, that's kind of your gauge. Birth weight, right? They should regain their birth weight by about day 10 of life, up to 2 weeks. They shouldn't lose more than 10% of their birth weight. So if they lost more than 10%, there's things to think of. Why are they losing that weight? They gain about 15 to 30 grams per day, so that's about a half ounce to an ounce a day in that very first young kind of time. And then their stools are normal seedy yellow stools. And wet diapers. In the first 2 days of life, the wet diapers is like 1 wet diaper on day 1, 2 wet diapers day 2, 3 wet diapers day 3, and then it goes on to be the pee every like hour or 2. So if somebody brings in a baby on the 2nd day of life and they only pee twice, that's actually normal. And they sleep most of the day. All right, so now the sick neonate. So this is kind of the mnemonic I like to use. And this is kind of the way I remember it, and I always write it down to, on my paper to see, okay, did I cross off these things? Trauma is unfortunately something very common, and NAT is something to think of. So always have it in the back of your mind. Heart disease, those are those ones that we get scared of, and then they can be hypovolemic, they can be hypoxic. Endocrine, so the congenital adrenal hyperplasia, thyroid disorders are also pretty big ones that you may see in the newborn period. Metabolic, so you get your electrolyte imbalances, so they can have hyponatremia, things like that, hypomagnesemia. Okay, are the inborn errors of metabolism, the things that we, we love so much. Seizures, formula mishaps, intestinal issues, which, again, we'll go into a little bit of each, not all of them, but some of them. Toxins, not as common in babies, thankfully, because they're not crawling around, but if they have siblings that are little, they're giving the baby some stuff that the baby shouldn't have. Sometimes parents don't know and they give medications that they shouldn't, or they give these natural medications. And then sepsis. Sepsis is the last one because we always think of sepsis, and that's great. We're supposed to think of it. You always cover for sepsis. You always assume that that baby has an infection. You cover, you give antibiotics, you do your blood culture, your urine culture, your LP if it allows. But I just want to make sure that we treat sepsis, but we also think of all these other things. So with your congenital heart disease, there's two kinds. There's your ductal-dependent pulmonary, so your ductal-dependent pulmonary blood flow and your ductal-dependent systemic blood flow. So the pulmonary ones are the ones that are going to be cyanotic, and those are the ones that are going to be blue. So those are the ones we think of, the T's, the TETs, the tricuspid atresia, all those. And then there's your systemic blood flow, which is more of your coarcts and your hypoplastic left heart. A good way to kind of, one thing to think of is if you do an x-ray, if you have a sick baby who's tachypnic and doesn't look well, you get an x-ray, and if they're tachypnic but their lungs are completely clear, you think, maybe there's something congenital, there's a congenital heart thing going on. So that's one thing to think of. You can do an EKG, may or may not be helpful. Sometimes these babies are so tachycardic that you just look at the EKG and all you see is just fast. But you are looking for other things. You're looking for widened QRS, you're looking for prolonged QT, just the things that you normally would look at in an adult. And then your chest x-ray, like I said, your chest x-ray can sometimes be helpful. Obviously you can do it. You can do an ultrasound, you can see if you see things, but they're so small that, the probe, it's really hard sometimes. And physical exams also sometimes hard too, because everything's so close together, there's so much noise. Sometimes it's really hard to hear what's going on. The cardiac exam is sometimes pretty hard too, because you just can't see if you can't hear a murmur. But a probe is easy enough to put on the chest. This is like the one we all know of and that you're always going to hear of, the boot-shaped heart, which is your typology. These are just like kind of things that you'll probably get on your test, like that one. Let me show that image. Just some other ones. There's this little egg on a string that's transposition, and then there's a snowman, which is total anomalous pulmonary venous return. But anyway, so like I said, echo you can do. A lot of us, you may not feel comfortable, but it's easy enough to kind of just see. Prostaglandin, that's the biggest one. So whether or not you're going to start prostaglandin. I think if it's pointing that way, I've started it before. We're lucky enough that we have a cardiac ICU there too. So a lot of times I'll give them a call and be like, hey, I think this kiddo has a congenital heart issue, and we're going to go ahead and start prostaglandin. And your dosing, you can always look this up, but it's 0.05 to 0.1 mics per kilo per minute. It's one of these medications though that if you're working in a hospital and you have your specialist all there, you can potentially start the medication and that baby may get better and you may be able to send them upstairs and they're done. However, it can cause apnea, and so if this is a medication you're going to start with a baby and you're going to send them out, this is a baby you want to intubate before you send them off to your receiving facility. Sometimes it can also raise the temperature, so make sure you have a rectal temp beforehand. Again, you're going to cover for sepsis anyway because you're going to assume that maybe they were septic and this put them over the edge, but you want to know what their temperature was before you started the prostaglandin. And then pressors, be careful with your pressors because you have to think of which kind of lesion do you have. Do you have ductal-dependent pulmonary lesion where you want maybe to increase the afterload because you want blood to go to the lungs, or do you want blood to actually leave the heart and get to the systemic circulation? So something that increases the afterload may not be the right thing. So thinking of maybe phenylephrine to increase your afterload, but something like a pump support, like the butamine or milrinone to get the heart going. There is something called the hyperoxia test. The real way to do it apparently is supposed to be like you get an ABG after a baby has been on oxygen for 10 minutes, and you're supposed to look at the PaO2. None of us are going to do that. A quick, easy way to do that is you put the baby on oxygen, and then in 10 minutes, if there was a 10% change in that O2 stat, then that's probably not, it went up, then that's probably not a cardiac disease. If it didn't change, then you think, maybe there's a cardiac lesion going on. Another thing is congenital adrenal hyperplasia. So that's one of the ones that can also give a sick baby. And remember, you don't have one of your enzymes along the pathway to make your aldosterone and make your cortisol. The most common is 21-hydroxylase, but there are other ones. And so with this, these are the babies that, if you have a female, a lot of times they will get caught ahead of time in the nursery, because when you don't make your aldosterone, you don't make your cortisol, you actually get more masculization because you get androgens, an accumulation of androgens. So the female babies will actually have physical findings that look abnormal. They'll have abnormal genitalia, so they'll get picked up. But the boys are the ones that actually get missed. So those are the babies that may come in. So again, if you get your bedside, I think here was your shock panel, and we have, you know, a whole blood, we call it, at my place, and then you can get quick sodium, quick potassium, and you can always get your lactate on that. So on the EKG, if you decide to do it, these babies will have hyperkalemia, but they actually tolerate really well. So most of the time they will not have cardiac arrhythmias from the hyperkalemia, but if you are concerned and it's high enough, or you do see abnormalities on the EKG, you can go ahead and give calcium gluconate. About 100 mg per kg is what you do. You want to give hydrocortisone, and it's just like a quick, just one-time dose, 25 milligrams IV. You don't have to calculate it, just give that 25 milligram. If you don't have hydrocortisone, if you don't have hydrocortisone, because you want that mineralocorticoid activity, you can give dexamethasone if you're in a pinch, and that's anywhere between 0.5 to 1 milligram per kilogram. And then finally, you want to give saline. These babies are dry. So you want to start with 10 cc's, always start low, and you can always go up, because if there's maybe a component of some cardiac disease, you can set them over the edge with giving them too much fluids. And then D10. At this young age, you want to do D10. I like to use a number 50, so D10, in order to get 50, you have to have 5 cc's per kilo, so that's just a quick way to get know how much D10 you're going to give that baby. You can give anywhere between 2 and 5, but if you don't know, just get to that number 50, so 5 cc's per kilo of D10. And then, so that's congenital adrenal hyperplasia. Then there's inborn errors, and those are the ones that there's a defect in the protein metabolism. These are the ones that get toxic metabolites in the CNS, and these are the ones that maybe will look a little weird, maybe have seizures, maybe be just kind of really sleepy. And then there's 2 kinds. There's your urea cycle, and that's one to think of. And then there's your organic acidemias. Now, the different ones are not important because that's for a geneticist, and that's, I mean, you may have a patient come in with an already diagnosis, but it's just the key thing to know, just the basics behind them. So urea cycle defects, you get the ammonia, and this is why you want your ammonia, because those kids will have ammonias very high, over 1,000. And then in the neonate period, greater than 100 milligrams per deciliter is actually abnormal. You'll have respiratory alkalosis, and then sometimes you'll have a compensatory metabolic acidosis. And then they may have, so initially they'll have a normal anion gap. Obviously the sicker you get, the more lactate you make, that's gonna bring up your anion gap. But initially, if you get them early on, you may have a normal anion gap versus your organic acidemias, which will have a mildly elevated ammonia. So those will be in the hundreds, not over the thousands. You'll have a metabolic acidosis, and significant metabolic acidosis and a lactic acidosis. And then you'll have your elevated anion gap. The key thing with them is that you need to basically stop the exposure to the protein that they're having trouble breaking down. So you want to make them NPO, and they're dry usually, so you want to give them fluids, you want to give them a bolus, but you also want to give them sugar, because the sugar is going to help them get out of that catabolic pathway and get them feeling better. So if you have 2 lines, you can give the bolus and then your dextrose containing fluids on the other side. You can do a Y connector, you can run the bolus and still give the dextrose fluids. And so you want your D10 quarter normal saline, you run that about 1.5 times maintenance. And that way you give them that sugar. You can go up to 2 times maintenance even, but again, watch how much fluids you're giving. There is something that you can give if they're encephalopathic for the elevated ammonia. I have personally never started it myself, and I think I would, I don't know the dosing, and it's very complex, it's beyond us. So I would say that if once you see that, you kind of talk to someone, pharmacists and some other specialists and kind of get the dosing of that. But there is something for it. But if it's high enough, or it's not going, let's say they're in your institution and they haven't been transferred out yet and they're sitting there, you may have to, if their number is not getting better, you may have to get in touch with a renal person, because they may need hemodialysis, and that may be the way to go. And then there's other things that you can potentially give, like carnitine, but again, probably not so much in the ER. So, yes.
How important is quarter normal versus half normal? Is that specific to these babies, sick babies, or any babies?
Yeah, I would just because of you don't even have to use half normal in the older kids anymore. You can just do the full NS, but with the younger ones, like I would say a month or 2 months, you do like a quarter, and then keep it there. And then once they're above 2 months, their kidneys can handle everything, and you can just do full D5NS. That's fine. You want to do D10 here because it's a little bit more sugar as well, which is good. And then intestinal things. These are the ones that we always get worried about. A lot of times parents will bring in their babies for vomiting, and we see it all the time, right? Is it pyloric stenosis? Is it just reflux because the baby's eating too much? Or is there something else going on in that belly? So intestinal catastrophes. So basically you want to make sure you don't just say this is gastroenteritis. That's one of those diagnoses that you always worry about anyway, but especially in the young baby. And then if there's no diarrhea, that's even more concerning. So bilious vomiting is always bad, just like adults. One of the most common things that you may see is malrotation with volvulus. So basically when they're developing, the gut doesn't rotate the way it should, so they have malrotation, and some babies will have no issues for a long time, and they may go on to adulthood and never have an issue. But then that malrotated gut does twist and they get a volvulus. So one of the things that you can do, so if you do an x-ray, so x-ray may or may not see things. It may see no air in the distal bowel, so that may be a clue. Sometimes it looks like a fairly, it's not an x-ray that you can make a diagnosis on. So one thing you can do is an upper GI, if it's available to you, and that may diagnose it. It's pretty specific, but it's not the most sensitive test. If there's something abnormal, the surgeons, your pediatric surgeons, if you notice that they have a significant gastric distension, then you may drop an NG2. IV fluids, again, because they're usually pretty dehydrated. And then since they've been vomiting, their electrolytes are off too, so you want to replace those electrolytes. And as well as antibiotics. It's just, again, assume sepsis, and then also assume that their gut, there may be a perforation, assume that there's issues going on. So always cover for those anaerobic bacteria that you can have. So give your standard, like ampin, gent here, or ampicillin and clavurin, whichever, or cefotaxime, if that's what whatever your institution does, plus something else. NEC is something you don't see very often, thankfully, because it's usually in premature babies, and they're usually seen in the NICU, but you can see it in newborn babies, and you can see it a week or two after they're born. And the treatment is the surgical management. A lot of times it's medical management, as long as there aren't any surgical issues. So NG2 or OG2, you want to do broad spectrum antibiotics, just like anything else. You want to do IV hydration and surgery. And like I said, surgery versus medical management. On the left side here, there's some pneumatosis right there. So Usually when you see these babies that have very distended bellies, they look really big and they're very tense. A nice thing to do to kind of examine babies' bellies, because sometimes they're just crying and you can't tell if it's tense because they're crying or because it hurts, is kind of like flex their legs up and then kind of like hold their feet together and go in between the legs and actually feel their belly. And a lot of times they'll relax their belly and you can really get in there. And sometimes you just have to lay your hand down for a little bit. Once they stop crying, you just kind of push down and you'll be able to tell if it's soft or not. And, or just examine them in mom's arms. Sometimes they just want to be in mom's arms and just the scent of mom, and then they're calm. And then the last one for intestinal is Hirschprung's. So one of the key things you ask is, did they pass stool in the first 48 hours of life? If they pass meconium, then the chance of them having Hirschprung's is a lot lower. It's not zero, but it's one of the ways that you can kind of get that offer on your list. They can have enterocolitis, so that's the big thing with Hirschprung's. It's the infection. Toxic megacolon, and that's kind of an example right there. Antibiotics if needed. I would probably, again, a sick baby, I would just give antibiotics. And then there's different ways to diagnose it. The ultimate, most specific diagnosis is actual biopsy, but some surgeons will do it in other ways. And then surgery consult. Excuse me. So just finishing up, seizures. They're very different than what we think of in adults, tonic-clonic. They don't really do that. They can sometimes just have staring spells. Sometimes they will have eyes rolling back. Sometimes they'll just have like bicycle rhythmic motions of their extremities. So those are things, if the parent says that there's something abnormal, believe that. Sometimes they'll even have videos of it. So it's really great to kind of get a video of it and see. So these may be the causes of some of your, when moms bring babies in for what they think the baby stopped breathing or something like that. This may be a cause, and this should be up on your list. You have your bruise now and all that stuff, all the things you think of when you want to go up brew and all that. So then just, it doesn't project well, but just, there's so many causes of seizures in a newborn, and so in a newborn I would just do everything. So basically meaning a full septic workup, check the labs, get the extra labs, really look at electrolytes, get a great history, and then ultimately they should be admitted. So stopping, so if you have status, benzos, still like your normal status pathway. One thing you may start with, you can do Keppra, but you also, phenobarb would be one that you would kind of go to rather than your other ones first, and that's just in pediatrics, in newborns, excuse me, neonates. And it's nice thing is that it's 20 mg per kg, just like most of your meds. So if you just do 20 mg per kg of those meds, more than likely you're fine. Hypertonic saline you can do for hyponatremia just like adults. And then the one thing though is that you have a seizure that's not responding to any med. So you've tried 3 different antiepileptics, you've tried your benzos. One thing you may have to do is pyridoxine, and you just give 100 milligrams IV. Especially here, we have a lot of people who are INH and they come from other countries. So if mom was on INH, pyridoxine is one thing to go through. And it's 100 milligrams IV, straight. Just a pathway. This is just a pathway of what we kind of said. So you just kind of go along, you find out what your baby, what the kid looks like. Are they really, really sick? And are they sick? But then they need some other things, and you just kind of go down the pathway, which is what we just said. So in summary, basically always cover for sepsis, no matter what. Remember the misfits. Just kind of cross them off your list as you go through your differential. Always check the glucose. That should be part of your vital signs, because that could do a lot. And you can correct a lot actually before then. Just save some extra blood in urine, and the lab will kind of sometimes tell you if you need to send it on ice or not. And then, so back to our case. So on the physical exam, the baby was ill appearing, had a weak cry, had poor tone. The head looked pretty much okay, except that the mucous membranes were dry. The baby was tachycardic, but you didn't hear any murmurs. Their lungs were clear. You didn't hear any wheezing or rales, but there were some costal retractions. The belly was soft, non-tender. You did appreciate some hepatomegaly. Normal umbilicus with a normal umbilical cord, so no umbilitis that you could see, but you still have the umbilical cord. Uncircumcised, you open the diaper, uncircumcised baby, but the genitalia looks pretty much normal to you. No hernias, because that's also something to look for. They were moving all extremities, but thready pulses, mottled skin, delayed cap refill, and very irritable baby. So irritable is bad. Irritable is like just as bad as, you know, lethargic. So the baby was placed on a monitor, airway was patent, O2 placed by non-rebreather, IV access was established, 10 cc's per kilo was given, you drew your labs. You got 4 extremity blood pressures and O2 sat showing differences in the upper extremity versus the lower extremity. So basically, you took a blood pressure from a preductal, which is your right upper extremity, and an O2 from your right upper extremity, and you took postductal, which is left. And you tapered the O2 because there was a difference, because it wasn't actually helping. You got an AccuCheck, reading was 40, gave patient D10, and you reviewed the misfits, you gave antibiotics, you deferred the LP because baby was a little too sick for the LP right at that moment, and then you started prostaglandin. The question, like I said, is to intubate or not. It is dose dependent. So the lower you start off, and if it does well, and you don't have to send them out, then you don't necessarily have to intubate them, but they have to be watched. If you have to go up on the dose and they start having apneic spells, just intubate them. And I mean, it's a touchy intubation, so you really have to have everything kind of ready, just in case they do poorly. Maybe you have to get push dose pressors, but you have it at the bedside. And then you get to the cardiac ICU and get that baby upstairs. And you die in there, have a coarctation. So that's the end of that case. And then questions. Oh, yes.
That's awesome, thank you. I have a question about the baby who's seizing. Could you talk a little bit about your thought process when and when not to get a head CT?
So most of the time we'll end up doing imaging. So if I feel the fontanelle doesn't feel bulging or full, I don't see any obvious deformities, I'll defer the CT for a little bit until we get the everything under, you know, obviously you have to get everything under control, and but if that baby stops seizing in the ER and you're going to tap that baby, I would get imaging for sure. You could do, some places will do like flash MRIs where they just get a quick, like 15, 20 minutes of it, and they just get a quick thing to look for, basically just looking for increased intracranial pressure. And you could do that at some shops, but CT would be the fastest. And you know, the radiation, but sick baby, I would just go for the CT. So basically everyone would do a CT before they tap that baby. And you're looking for not just increased intracranial pressure from a mass, but you're looking for blood, for NAT, and those are pretty much the big things. I think there was another point.
You're talking about the elevated potassium. I've seen some of these babies when potassium is greater than 6. Is that partially because a lot of times we collect it from the heel stick versus an IV line, or is that actually okay and normal? Because I've had them come back quite differently between the heel stick and the
Right, well, some of it is hemolyzed, and I always ask the lab if it's an elevated number. I always call them, because most of the time they'll call you, or they'll like write a little description, hemolyzed. Sometimes they're not, and babies can do fairly well with potassiums of 6 and be okay. Once it starts going over 6, closer to 7, that's when I think there's something else going on, and then I would be a lot more careful with that baby. I would definitely get an EKG to start with, and some people, if they start to see, if they see anything, or if the number's too high, they'll just give calcium gluconate just to be safe. And that's the one that's more preferred, just because of calcium chloride, just, you know, issues with lines, and you don't want it to sclerose and extravasate. But generally, they tolerate things a lot better. And actually the norm up until a certain age is as high as 6.
I usually get a heel stick.
Yeah, the only time I would do a heel stick. Yeah, I mean, the only time you really do a heel stick is like a bilirubin, if it's like a bili check. If the baby looks fairly well and the baby looks a little yellow, then that may be the time to do the heel stick. But other than that,
Last question or comments?
All right, so let me just talk a quick thing about my like a little memory that I have here. So again, I think everyone always talks about CCT because it's always crazy. But I remember it was probably like my second shift as a senior, and so you're panicking. You're like, oh my gosh, I hope I don't send someone to the CAT scan that's going to code, or I hope nothing goes bad. And of course, it's one of those busy days, it's in the summertime, and so you have your trauma that comes in, and then you have your ICU patient that's boarding but is sick, and then I just remember I had a great team, and I remember running around the ER and like literally going in and out of rooms, and we had to like stabilize the acute pulmonary edema patient. I had a lady, I still remember her, 80 years old, like 80 plus, coming in on a stretcher for angioedema, and I just remember seeing her tongue like hanging almost to her chest, just sitting out of her mouth, and she's just kind of sitting on the stretcher, and I'm like, oh my gosh, you know, I'm dealing with this trauma. I said, get anesthesia, call them, get this lady out of here, please, you know, because that's the last one you want to like not have an airway on. And so I just remember like that anxiety, but I remember feeling comfortable, like I knew what I was doing, I could handle it. So where I work now, actually about a year ago, there was a pretty bad daycare accident. A guy ran somebody off the road, and he ran into a daycare, and it was a time when kids were still in school, at nap time actually. So we had very bad traumas come in, and I remember, you know, we didn't know the extent of what was happening, and all of a sudden, like, you know, patients came in, like 5 or 6 trauma patients, and some of them were very sick, some of them were not as sick. But on top of that, I'm in, like, the way our ER is set up is we have our acute 1 area, which is where you handle your trauma and resus, plus usually like 13 rooms. And usually they tend to put the sicker kids in that area, and then you have acute 2, which is also some sick kids, but then also your fast track. So I remember being in that acute 1 area and having to do the traumas, but then also we had a TET spell come in that had to get, like, we had to treat. We had some bad asthmatics and, you know, a couple of fractures that needed sedation, and orthos kind of standing there, you know, like waiting to do sedation, waiting for bone fractures to come in for the traumas. And I just remember thinking, okay, what would I do at the county? And I always tell people that back at the county I did this. So, you know, we just kind of worked, and, you know, you just start directing people, you start grabbing things, doing IVs if you have to, putting in IOs, all that stuff. So I just remember feeling comfortable, and I remember just saying, I could do this, and we did, and we did well. So, I mean, your training is going to be great coming from here.
Thank you very much, Dr.
Thank you.
Melendez.